It's my pleasure to introduce our last keynote speaker. Note, there's another session after our last keynote speaker, and that's Dr. Kavi Singh. You've heard him speak already, and you've heard one person's introduction, but you haven't heard mine. You know that Kavi's an emergency physician in Montreal, Quebec, at McGill, and you may know that he first worked for about 15 years, I think, in northern Quebec, and then came back and did his emergency medicine residency. But Kavi and I have sort of forged a new friendship over wilderness and rescue medicine. And you saw a lot of that in that last video. Kavi and I met at the Canadian Association of Wilderness Medicine meeting. And so some things you don't know about Kavi is that he's actually got his diploma in mountain medicine as well. He's active in whitewater sports and also combat sports, so don't mess with them. Under Canadian Association of Wilderness Medicine, he had a leadership role there, and in 2023, he won their Mount Edith Cavell Award for an individual who has made outstanding contributions to the field of wilderness medicine. And the last thing I can tell you, much like Stephen Hearns, it was my pleasure to go on a hike with Kavi, and he's fit, too. Dr. Kavi Singh.
Alec asked me a while back, hey, can you give a talk and just kind of tell your story? And I said, yeah, I think I can do that. So that's the talk today. And rural, remote, Indigenous communities, Northern Quebec. But honestly, this is a pan-national situation and a pan-global one. So you can take my talk and it applies equally well to BC, Alberta, Manitoba, Norway, Australia. I've got no disclosures. I do partner work with the Canadian Red Cross, Canadian Space Agency, and Paratus. My wife had hoped to be here, but a family thing came up, but I got to thank her. She's a superhero. She lets me do all this stuff and is holding the fort at home. Thanks to MRBC, and thanks to all the families and patients who let us in, who let us help and teach us. I'm going to be sharing, with their permission, some stories today. And just a territory acknowledgement. We are on unceded ancestral land of the Musqueam, Squamish, and Tsleil-Waututh nations. I work in USG, James Bay. And I was talking to Gary last night. I think he stepped out. But I was like, Gary, what's, these territorial acknowledgements? Yeah, they're nice, but they're kind of empty. If you have a chance, visit the res. So take the C bus, hang a left to Mosquito Creek, and just check out the res. Firsthand, just to kind of see what it's like, because that's how you get to know the people and that's how you get to know the reality. So when Alec asked me, hey, do you know anything about First Nations medicine and retrieval? I kind of looked at him. I was like, dude, I'll bake you a cake, run down Robson Street naked wearing a rubber ducky outfit, wash your car and give you $500 if you can find someone who knows more than me. So I'm a director of resus at McGill EM as well, and one of my colleagues, we were talking about teaching, and he's like, yeah, wounded physician is the best teacher. And I learned a lot of hard lessons, and at some point it was the get better or get out. And my superpower is I fail frequently, but I also take the time to learn from it, and you can learn a lot from failing. So this I kind of already went through. I'm mostly up in the Hudson side of northern Quebec. And I read Stephen Hearns' book many years ago, and all the content is good. I would highly recommend you read it. And then the next step I took was, well, okay, how do I take all of that knowledge and actually contextualize it and translate it into something at midnight when I've got a sick kid dying in front of me? Like, I can only remember 2 or 3 things at a time. So that's what I spent the last many years working on. I'm going to try playing this video. So I'm going to try to hit click and go. No. Are you guys able to? Yeah, here we go. It's 2 minutes.
Know what happened to him?
One, two, three! Here we go. Over the shoulder! Okay. Let's go. Let's go. Hang on now. Hang on.
doctor as soon as possible. Just have that guy came with his friend banging at the door. Don't know trauma, abdo, really agitated.
Okay, Nilsi, I need an IV, O2, monitor, cardiac monitor, call the RT, do the vitals, do everything, okay?
We cannot even get his clothes off.
Okay, let's recap. His fast is positive. There's no lung sliding on the right. Okay, let's go through the ABCs. His airway's intact. His GCS is decreased. So.
Do you want to intubate?
No, I don't think we have time. Let's just get an oral airway and LMA and take them with us. Okay?
Perfect.
His breathing is poor. His rest rate is 22. His SAT is 92%. So let's get a needle.
Do you want a chest tube?
No, I don't think we have time. Let's just do a finger thoracotomy after the decompression. Okay. And C, his blood pressure. Do you have the IV?
No, I can't. I've been trying. I can't have one.
Have you guys done an IO?
Only on mannequin.
Okay, pass the IO.
Eduardo, you'll do the ultrasound. Sam, you'll do the monitor. Antoine, you're the RT. You'll take the head with Lori. You'll do the intubation, Lori, if it's necessary. Sarah, can you put in a right chest tube for me, please?
Yes, I'll get on.
Okay. Nelsie, can you call for the massive transfusion protocol, please?
Yes.
Let's notify the surgical team and prepare the OR.
So that's kind of a quick sort of a intro to what it's actually like up when you work far and you don't have a lot of stuff. That scenario is not actually that different from what actually happened. So today I'm gonna share some stories with you. It's gonna be stories involving baby reindeers, some werewolves, and silver bullets. And that is me, the little baby reindeer. When I first started working, I got a call one night around 3 from Veronique, who is a woman of very few words at the best of times. And come now, click. And I was like, okay, that's like, put the pants on, you don't brush your teeth and you run. So I ran over, got there, police car, doors wide open, ran in. She's hanging off the hand of a guy who's about 6 feet tall with crazed eyes. I was like, what happened? And like, we think he got stabbed. So I was like, oh, I had just done ATLS. I'm Superman, ATLS stud. So I yelled out my orders. Okay, everyone, close off 2 IVs, monitor oxygen. And nothing happened because it was me and her standing in the room. So I was like, okay. So then my primary survey became, well, the guy's standing, so the airway's good enough. He must be breathing good enough, and he's got enough of a blood pressure that he's standing, and his brain is working well enough that he's standing, so that's done. I was like, I guess I'll try cutting his clothes off next. So it took me, take a guess at how long it took me to cut his clothes off. Throw a number out there. A little bit less, 10 minutes to cut his clothes off. And this was summer, this was not winter, this is not a skidoo suit. Because he was just so agitated and there's no one to hold him down. And at this point, I started to depersonalize a little bit. I'm looking down going, yeah, this is not like the ATLS course. In 10 minutes, everything was done and you're in the OR and I haven't even got the guy naked. And I'm like, what is going on here? So I called a buddy, he said, yo, what do you think? He's like, just go, 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 go. So we drove, hospital's about an hour away. Halfway there, he became much less agitated. And his tummy, and we had called him and said, we're coming, he's been stabbed, prep the OR, anesthesia, everybody. His abdomen doubled or tripled in size by the time we got there. And we were fast. We got him intubated up in the OR within 5 minutes and he died on the table from a splenic laceration. Now, American College of Surgeons stats will say rural trauma mortality is 6 to 10 times urban. Northern Quebec, the McGill Trauma Group did a study a couple of years ago, and the numbers blew me away. I was like, you guys made a mistake in your numbers. So I actually recrunched their numbers, and they didn't make a mistake. 25 times more trauma mortality, and when you include suicide, pretty well 50 times more. So that's crazy. Like that doesn't even register in my head. Like, and I kind of know that, but I was still surprised. So that's one werewolf. Another werewolf is the delays. I was teaching ACLS last year, and the doctor's going, "Wow, we had to wait 5 hours for a medevac," and I was like, "Oh my God, you're so lucky! Like only 5 hours? I've got people waiting 48." So medevac delays, and there's a dirt shovel there because there's a dirty secret. When you try to find out what the actual medevac delay times are anywhere, it's really hard to find numbers. And I was able to find out how many camels have been disqualified for Botox use from the annual beauty contest more easily than I can find out average medevac wait times across the country. And that's weird. That's not okay. Like that's a problem. Quebec has an evacuation service. Its main issue is it's just not big enough. So we have 4 Challenger jets. They're staffed by physicians and flight nurses. Many of my colleagues work on it. They've asked me to work. It's a great service, but the problem is there's only 4 planes and Quebec is big. And then you have all the attendant complications such as weather, et cetera, et cetera, et cetera. And I was talking to Aaron yesterday. If you could just be honest and say, listen, 30,000 people live north of the 50th. Sorry, we can't invest the money to get you medevac service. That would be actually more honest than the putzing around that's happened over the last 25 years. And Hydro-Quebec brings in about $3.5 to $4 billion a year from all the water from up north. So I think there's a question of whether there's a social or a moral imperative that maybe there should be a better medevac service up there. The other werewolf that comes up is it's actually kind of complicated to define what is pre-hospital and what is hospital and what actually is rural or remote. Is there a road? Is it a winter road? Is it paved? Is it not paved? And even pre-hospital, hospital, if you have septic shock, I can give antibiotics, pressors, fluid, and I kind of function more or less like a hospital where I am. If you're stabbed and you're bleeding to death, I need to get you to blood. But if you're a small hospital and you only have 4 units, you're not much of a hospital either. So there's a lot of nuance in what we talk about. It's not so straightforward as hospital, pre-hospital. It gets once you start digging in, it gets much more complicated. A lot of people, you got water at your table. We take water for granted, and we shouldn't. Kashechewan, the Ontario side of James Bay really lives in poverty compared to the Quebec side, and they just got evacuated again for cryptosporidium. It's been 25, 30 years. They've never had clean water, and Aaron alluded to it yesterday. ER diversions are a major problem. It destroys the service locally, and people have to wait. So the things we take for granted, up north you can't. And we're talking about providing advanced medical care. We can't even get the basics done in some of these places. And I alluded to this a little bit before. A lot of the strategies we use to try to get better are not that useful. And it dawned on me one day as I watched a colleague struggling with a resuscitation, and I was like, she's pretty smart. And I'm not the smartest guy in the world, but I'm probably not the dumbest guy. And we've done all these courses for like 15 years, and we're still not feeling so good about ourselves. And you end up, asking, am I the problem? And at some point you realize, well, maybe I'm not, but a lot of moral injury, distress, and you start to wonder whether, am I a werewolf or am I part of the solution? So let's talk a little bit about teams. Let's say downtown east side, house fire, a 50-year-old guy comes out, airway, thermal injury, 30-40% second-degree burns to his body surface area. And he's got a history of cardiac disease. So he's going to need fluid, but he's also got a weak heart. So this guy needs care. Now, who would want this person to have the best care? Everyone. We're going to play a little bit of Wheel of Fortune now. Best care is provided by best, in red, team. I don't think that's debatable. you want to have an intensivist, plastic surgeon, nurses, the whole crew. Like this is not a question, right? There's a reason hospitals run the way they run. There's a reason we have a trauma service. There's a reason we have an intensive care. It's team-based care because that's the best care. Now, if we take the same case to Hazelton, I would argue this patient still deserves the best team. He came in on December 24th. He had taken Molly and Percocet the night before. This is what the family thinks. This is all published online, Facebook. And he came in the next morning unwell. They called me. I wasn't on call, but I have an agreement with all the docs. I will come in for any emergency 24/7 as a clinical, kind of like the CCP in the back, in the hedges. So we had lost power the night before, and that's usually not a problem. You have a generator that kicks in. And he came in and he arrested. And so we were there. We started doing CPR, and about a half a gallon to a gallon of just fluid, vomit, everything came out. And because we had a partial blackout, the suction didn't reset. So the one patient who needed suction in the last year, we didn't have suction. And you're like, what the hell's going on? So we managed to find a portable suction. He had, the lab came back and said, we can't calculate a pH on him. So we did a resus that was out of this world. We brought him back twice. We got a pH of 6.8, and we got him down to Montreal. He had no business surviving this. We got him down to Montreal for possible ECMO. And the only reason it happened was because of the team. If I'd been there alone, I could not have done this. Like it's not even a question. I needed an expert doc on the airway with another doc as an RT, a bunch of nurses, which gave me the time and space to really manage things on a higher level and get all the I's dotted, T's crossed, all the little things that I had time to do because I had a couple of super team members, got this guy back. A couple of years ago, we had some major fires in northern Quebec. And a lady came in one day with lower GI bleeding pretty briskly. So I was like, well, we need to get you to hospital. So I called the hospital, and the fires were nearing Chibougamau. And they said, yeah, sorry, we're closed. I was like, yeah, but you're answering the phone. You're not closed. She said, no, we're closed. I was like, no, you don't understand. She's bleeding to death. You have blood. She needs blood. She's coming. She's like, no, we're closed. And so we got into a thing. I was like, if you're answering the phone, you're taking her because she needs blood. The town had been evacuated. The hospital was empty. They lost their staff. So finally, the police brought blood to us. They drove as fast as they could, and we got blood into her. And then we got a helicopter to take her out. And now we had a dilemma because we have no functioning referral hospital. So our director of professional services is a physician who actually taught me. He's worked in the field. He said, what do you need? I said, what can you get me? He said, if I get you a helicopter, will you take it? I was like, damn straight, I'll take a helicopter. So a helicopter came back, and we had a helicopter that night with a trauma flight nurse from Quebec City who I knew, and a paramedic. And so I said to them, hey, if anything crazy happens tonight, guys, I'll give you a call. So 8 o'clock that night on the other side of town, there was a scream, and it's the kind of scream where I didn't hear it, I was too far away, but my colleagues who lived nearby heard it. You know something's wrong. And so they popped their heads out, and they saw a 5-year-old who had just been rolled over by an F-150 by his mother. So they got CPR, and they got him in very quickly. My wife was at the clinic doing paperwork. She heard this. So she drove home and said, go to the clinic now. They're going to need you, and I'll come as soon as I get someone to watch our little guy. So this was probably the biggest resus I've done in my life. So traumatic cardiac arrest. We got bilateral holes. We intubated. We got blood driven again from Shibugamu a second time. And I called the helicopter crew and I was like, you need to come. And thank God they were there because I had a trauma nurse and a paramedic were there to help a really experienced team. And we brought this little guy back. And we were doing stuff that the tertiary care trauma nurse was like, what are you guys? I was like, no, we're not. We're pulling the blood out of the bag and it's going straight through the IO. We're not, there's no filter, there's no lines. This is just bang, 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 bang. We need to get volume into this kid. He was hypoglycemic. We brought him back. And then they kept saying to me, you're coming on the helicopter, right? Because they did not want to go alone. I was like, yeah, don't worry. I'm on the helicopter with you. And unfortunately, his head injury was a little too big. And I'd already treated him for it prophylactically, but we started to lose the battle. But the process was excellent. We did a good job there. It was worthy of any children's hospital. So if you got the best care at the end and you want the best care at the beginning, I would think, and if it was me, I would want the best care in between as well. And so the common denominator is best team. And there's a lot of debate about who should go, who shouldn't. And for me, it's kind of a superfluous debate. I think people are getting lost in the weeds. You need the best team for that patient at that time. It's as simple as that. This is a quote from the paramedic who was there, Emilien. I love working with physicians and nurses in pre-hospital. The level of care that's provided is to a higher standard without being disproportionate. Physicians and nurses are exposed to the diagnostic pathway and the final dispositions, and so they're able to anticipate where things are going and make early decisions based on that. And that's the strength of having advanced providers. Okay, so I think the whole debate about who does this, that, or the other thing, it's misguided. Quebec does a few good things. Well, they introduced trauma systems back, it was 92, and we decreased trauma mortality by an astounding 35-40%. We used to have doctors on the road. They took, where the blue arrow is when they took doctors off the road. And one of our big problems is our neighbor to the south in the US has a particular system, and they have a lot of trauma, a lot of penetrating trauma, a lot of gunshots. So one of my colleagues, we used to send people to shock trauma in Baltimore to train, and we don't anymore because it's just so out there. You roll into shock trauma and boom, the emergency room turns into an operating room within a couple of minutes. And then it's essentially an intensive care unit. The entire building is a trauma intensive care unit. So it doesn't really reflect what we have here. And so that's not the model for the rest of the world, though. In the rest of the world, so we had doctors and ambulances, but they were unequipped. And so it's kind of, Quebec is always kind of trying to do the European thing, but they didn't really do the full French model. The full French model is when the doctor comes, it's a mobile ICU. It's not just a doctor with an IV kit. So this is where, you have to really look at the details. And one caveat I'll give you is that experience is not necessarily expertise. And when I talk about having the best team, I think this should be one of the mandates or rules that MedResponse takes on, is training rural providers to a higher level of care, ensuring the highest level of care en route, and then having the highest level of care when we arrive. 20 years later, I got called by a colleague Saturday or Sunday morning, and she said, hey, can you come give me a hand? I got a guy who's agitated. And I was like, yeah, sure, okay. So got in the car, got there 4 minutes later. They were this is around the time of COVID, they're in the COVID room. So I walk in and I see them doing CPR. I'm like, you just called me to say agitated, now he's dead? Like, what? What's going on? So So she said, I think he was stabbed. And I don't know, will this video play if I click?
Really?
Okay, aspirating. Aspirating. Okay, resume CPR.
So as soon as it happened, I said to her, stick the probe on, look for tension pneumothorax or tamponade. She said, I think I got tamponade. I said, okay, boom. I ran to get my spinal needles, and we had a needle in him within about 130, 140 seconds, which is pretty fast, like for a place that's not a trauma center. Now on the right, there's a picture of a guy named Stuart Swadron, and he's a fairly well-known emerge physician. He actually trained here at Lionsgate initially. Now he's at LA County. LA County has a lot of trauma. So Stuart has probably seen, I don't know, 10,000 times more penetrating trauma than me. So I was listening to a podcast by him, and he was talking about, you know, the mental shortcuts and heuristics that you develop as an experienced physician. So penetrating trauma, yeah, the money's in tension pneumothorax and tamponade. And I thought, you know, this is interesting. Somehow, without his experience, I made the same decisions as him within 4 seconds. So what's going on here? Because I don't have the exposure to trauma that he has. And one of the problems is everyone who's been up here, Steve, and everyone will tell you the same thing. We've gone outside of medicine to learn how to do medicine better. And this is my idea of what performance under pressure is. Something bad or high consequence is going to happen unless you use a specialized skill in a very short period of time. And so there's me. If I don't roll that kayak, this is flat water, so it doesn't really matter. I'll just bail. But if you're in moving water, it's going to be a thing. If you don't get the boat up, you're going to smack your head on something. So, and this requires a very different training than what we're used to in medicine. We don't know about this. We are masters of information, and so we try to learn more and more and more. And the problem is, the more you learn, the worse it gets. Because it doesn't matter what you know, it's what can you pull out at the second you need it. And if you have too much stuff, it's not going to work. So this is where I would encourage MedResponse, dare to be different. If you train the same way, you're going to get the same result. And this has to be a paradigm shift. Is Jamie gone? I think Jamie might be gone. So we're all saying the same thing. And I was just talking to Kyle, same thing. Andrew Petrosoniak calls it radical transparency. Yeah, it doesn't matter if you know what the diagnosis is. It's actually irrelevant. I want to see your process. Hey, can you bring back and oxygenate someone who's having trouble, regardless of whether it's CHF or pneumothorax or whatever? It doesn't actually matter. And this guy makes $285 million a year. And this is what he does.
And Ronaldo's whipped it off his toes. Lovely stuff. Oh, brilliant piece of skill.
Ronaldo. There we go. Listen to that.
Now you get paid a lot less. So he basically gets paid $285 million to put a small ball through a big hole. You get paid, I don't know, Dr. Coggins, what do you get? $28.50 to put a very small object through a very small hole. And I would argue that this is a much more important job than what Cristiano does. And what we need to do is train people to be robust, resilient, and agile. Stay on the horse, and when you get knocked off, know how to get back on and be good enough that you can predict what's going to happen. And I mentioned this slide before. This is where you have to have structured training. And you really need to rethink how you do it. I teach ACLS, and I think it's a hot mess. So on the left is what you're supposed to try to remember during a code. And I was like, for 15 years I tried, then at some point I was like, this is garbage. And so this is my version of ACLS. If it's not moving, you make it move. If it's too slow, speed it up. And if it's too fast, slow it down. And it seems funny, but it's actually really effective. And if you lose your mind, have a brain fart, use electricity. It's always safe. Who knows the H's and T's? So this is good for an exam. And for 10, 15 years, I was like, okay, which H? Did we get the fourth H? I can't remember. Which T? And then you go back and study some more. And then at some point I was like, this is wrong. So this is what I do now. This is how I teach it. It's either pre-cardiac, cardiac, or post-cardiac. That's it. And then as you get a bit more experienced, I'll add in some diagnoses. But now I've mated this to our workflow, C, A, B, C, D. And I actually cycle through this when I'm doing a code. I look back at when I first started, and I would try to get through the H's and T's once. I would say probably on average, I cycle through this mnemonic 15 times during a code now. And each time I'm adding layers faster and faster and faster, because I can cycle through it so fast now that my brain is actually free to do other stuff. My brain is free to look back and go, that's a new nurse, and she does not know how to use the perfusion pump. I can tell by the look in her eyes. So we are not going to do any perfusions. Hey, gang, a little change of plan. We're going to do push dose drugs only. So boom, I've just eliminated that whole issue. I don't know if any of you follow jiu-jitsu. This is one of the greatest grapplers of all time, Roger Gracie. So I got to practice with him. We practiced for 4 days. His main thing is advanced basics. So we did a very limited number of techniques for 4 days. And at the end of 4 days, he sat us down and said, okay, guys, we practiced for 4 days. And I want you to understand that you don't know this. You have a concept or a notion of what we did, but it's not going to work. And I was like, man, if you do a 4-day airway course, what do they tell you at the end of it? You're an airway master. And it's a very different attitude. Professionals practice until you cannot get it wrong. And that's what is missing in our pedagogy, I think, to a large extent. And I've seen this happen. I've seen colleagues who've done airway courses fail at an airway, and you can see the look in their eyes of just like, what is going on? And it's like, yeah, the course is not enough to make you can't master something after 16 hours. It's not a thing. So we deal with complex problems. We try not to go into chaos, and complex problems is a very specific definition. They're unpredictable. They can have competing tensions. And so when we train, I said this morning, don't sim. There is a place for sim, but it has to be strategic. It has to be fun. You got to make it safe, and you should play during sim. And then we take you through something simple, and then we make that perfect, and then we make it complicated, then we make that perfect, and then we'll make it complex. There's no point in me throwing you a case where someone's unconscious, hypotensive, with blown pupils, because it's too much. You're going to fail. The train will derail before you even get started. And this is what we do in sports. And the way we increase the pressure is we're going to increase the pressure. And I was just talking to Kyle over lunch. If you make a mistake, we stop. We fix it and go back. We don't just let you keep going and going. We stop. We teach you troubleshooting. We add constraints. Hey, now suction is not working. What are you going to do? Oh, yeah. Okay, close your eyes and try it. Okay, your laryngoscope light goes out. What are you going to do? And this is how you get good. We start throwing trouble at you, so that when it comes to the real situation, you're not phased. You're not phased at all. So sort of wrapping up, Mike asked me to find examples, and we've had lots of examples the last couple of days. One of the first examples that came to my mind was CMERT. CMERT is a forward aeromedical response team in the Canadian military. And the idea is, for wounded soldiers, we take the ICU in the hospital to you into a non-permissive zone. So it's a fully combat capable, kitted out helicopter, a Chinook, and inside we have everything you would need, hyper organized, so that you can literally reach behind you and know where the equipment is without even looking, because it's so loud you can't hear anything, so you can't talk to each other. So this is a high performance team. And I was actually talking to Andrew McLaren at Stephen's course, who happened to be here, who's the medical lead for CMERT. I said, Andrew, tell me, for me, it's inconceivable that you could have a CMERT without a full team. Like, I can't even wrap my head around the idea of having the most severely traumatized people without everyone there. 2 med techs or paramedics, flight nurse, and physician, plus the combat crew, plus the pilot. I was like, it doesn't make sense to me. He's like, yeah, it wouldn't make sense. Just doesn't add up. You need all those team members there to provide the best care. So we had lots of examples around the world of this being done. So it's not like it's unknown. And there's even more. SAMU in France. In Canada, we have Orange, Stars. There's many, many, many examples of how this works and how it works well. The principles are agnostic. You want the best team for the best care. The specifics will vary depending on your geography, location, distances, pathology. And the devil really is in the details. And this is where you have to spend the time. You have to do a system analysis and figure out, okay, where is our time best spent? What's the biggest yield? And this is where I think we get lost in the weeds of all the studies. And I'm too bad Jamie's not here because I want to reference Thick Boy again. You know, Mike Christian published a paper in the last couple of months, and I read some of the critiques of them, and some of them are just, they were a little painful to read, such as, oh, maybe in the future there could be randomized control studies done. And I was like, you fundamentally don't understand science if you're saying that. Like, this is a complex adaptive system. A randomized control trial can't be done. Like, it's not a thing. You can do a randomized control trial for what Thomas suggested. Hey, we have a closed system. We're changing one variable, and we're going to see how it adds up. But these are complex systems. You know, when Roger Gracie's fighting, he's not doing a randomized control trial. He's doing multiple iterations over and over and over to see what works the best. And so we have examples from around the world, and I think it's important not to get lost in the weeds and step back and focus on the big picture. If you want the best care, you need the right team to the right patient at the right time. That I don't think is really debatable. I think that's common sense. I believe that the cause is noble, but it's not always an easy road, and sometimes the right path is not the easiest one. But I think it's a road worth taking. And most of it's not medical. It's change management, financial, and what is required is commitment, cooperation, and a lot of patience. And London HEMS, I think, is a really amazing organization, and they sum it up here. The best care is not high tech or super fancy. It's just really, really good basic care that's delivered to the highest quality assurance. And that takes a big commitment. So I can't remember where I got this diagram from. It's from a BC government website, but there's a lot of factors that go into First Nations, rural, Indigenous health. And at the bottom, I just circled innovation, because that's what it takes to change the system and to make things better. Sometimes you have to innovate. So